This is Danielle Ferkingstad. I am a nurse anesthetist from the anesthesia department here at Hudson Hospital. Today we'll be talking about caring for the patient with a laboring epidural. The objectives are as follows: benefits, indications, and contraindications of laboring epidural anesthesia, pain transmission and modulation, setup and assisting in the placement of the epidural catheter, understanding the pharmacodynamics and pharmacokinetics of common opioids and local anesthetics, assessment, documentation, and management of side effects and complications of the laboring epidural, as well as patient and family teaching. The benefits of epidurals are that they provide excellent pain relief, reducing maternal catecholamines, decrease maternal hyperventilation, the ability to provide pain relief for the duration of the labor, facilitates delivery of twins, delivery of preterm infants, and vaginal breech delivery, blunts the hemodynamic effects of uterine contractions, beneficial for patients with preeclampsia, mitral stenosis, and spinal cord injury, as well as in intracranial neurovascular lesions. Indications for laboring epidurals: any pain experienced by a woman in labor, but medically beneficial to reduce the stress of labor. ACOG and the ASA state that in the absence of a medical contraindication, maternal request is sufficient medical indication for pain relief. I'm going a little crazy with the screen here. Anticoagulation therapy, we talked about that if they're on any sort of Coumadin or heparin or any of those types of things. Just really alert the anesthesia provider if you know that your patient's on any of those types of medications. We'll talk about that a little bit later in the slides. Decreased fetal heart rate or variability or late decels. Really let your anesthesia provider know if the baby's not doing quite well. We may decide to hold off in the event that we may have to rush to surgery for a set C-section. We won't want to decrease the perfusion to that baby who's already compromised. So again, just another piece of the pie that you'd like to discuss with us. Any known allergies and medication given, that's for obvious reasons. Some relative ones would be systemic maternal infection, pre-existing neurological deficiency. If the patient had some weakness in their lower extremities, we wouldn't want to be masking any of those types of things with a epidural. Patients with MS, the literature states that they are safe for those types of patients. Some literature says it exacerbates their symptoms. Some say it's better for them. So that, again, will be provider specific. Mild or isolated coagulation abnormalities. If the patient has preeclampsia, we really wouldn't want to be pushing that patient to full-blown HELP or DIC. We really want to be watching the platelet count before we go ahead and put an epidural in that patient. And right now it stands that we need a platelet count 4 hours, within 4 hours of placing an epidural. If that patient is borderline, they're sitting at 100 or so when the epidural is placed, we would want to go ahead and repeat that again before we take the epidural out as well. Relative and correctable hypovolemia, if they're really on the border with their blood pressures, those kinds of things, we'd just be really careful. Another piece would be poor staffing. If somebody can't be with that patient one-to-one, or that patient doesn't have any family with them, that'd be another reason why we wouldn't want to put an epidural in a patient. Other contraindications are determined by the anesthesia department at the time of evaluation. If they had some sort of heart condition or any kidney disease or any other reason, we'd go ahead and do a full assessment there. The intensity of pain in labor, I find this really interesting. This is depicting pain syndromes. Causalgia, which would be a nerve type pain, is pretty high up there, but they're saying that having a baby actually is as high as amputation of a digit, which I think would be pretty significant. So when patients are complaining of labor pain, it's very real. Most of us have had children and can understand that. This toothache is kind of lower here, and I've had a toothache, and that does not feel very good. So just really being cognizant of the patient's pain, and whatever they feel their pain is, it's real for them, even though we may think otherwise. Talk about spinal anatomy here. You'll see the ligament of flavum is one of the ligaments right before the epidural space. That's a really tight, thick ligament that the epidural needle is passing through. And once we get through that into the epidural space is where we lose that loss of resistance and the water free flows in. Then you have your dura mater, your arachnoid matter, and your pia mater. So in the arachnoid matter is where the subarachnoid space is where the spinal fluid is, and that's where we would do like an ITN. And if we talk about a wet tap, we've gone way too far through the ligament flavum, through the epidural space, and then into that subarachnoid space, which we don't want to be there. That'd be a really dangerous place to be injecting a large volume of medication. We would cause quite the emergency, but we'll talk about that a little bit later in the slides here. Just another picture, different views of the same thing that we talked about with this screen, and you can take a peek at that as you wish. But sometimes if you look at this picture over here, you can see like the spinous process here. Sometimes if we're having a hard time getting through, sometimes we're bumping there. If we're off to one side or the other, we're hitting some of these pedicles on the spinal processes. So it's really important to try to go straight on as we're placing that epidural catheter and not get off to one side or the other. And sometimes if the patient's hips are not very even, that could happen too, where it's closing out the space on one side or the other as well. So very important to have good patient position and those kinds of things. And again, we'll talk about that further down the slides. We talked about the spinal anatomy when we looked at the screen, saying that the dura mater is the outermost layer covering the nerve roots. The arachnoid mater is a thin spider-like, and it forms the middle layer. Subarachnoid space is beneath the arachnoid mater. It's filled with the CSF, and the piano mater is the innermost layer that adheres tightly to the spinal cord and brain. Your epidural space, it contains fat, epidural veins, lymphatics, segmental arteries, and nerve roots. The fat surrounds and protects the spinal cord. When opioids and local anesthetics are used for epidurals, they collect in the fat. Medications used in epidurals act on the receptors in the dorsal horn of the spinal cord by diffusing across meninges and the CSF. Sometimes you'll see, as we're placing that epidural catheter, or actually the needle, that will hit some of these big veins. And when the patient is contracting, those veins actually swell. And so at that time, it's just advisable to wait, let the patient get through their contraction so that we don't end up going through one of these epidural veins, because we have to start the whole process over. As we'll talk about later in the slides, that injecting a large amount of medication into some of these blood vessels would be very catastrophic. Dermatomes, these are interesting little things. They're area of cutaneous sensation supplied by a spinal nerve that is anatomically identified as it passes through an intervertebral foramen. These dermatomes have been placed on an anatomic map based on cutaneous sensation called the dermatome map. So these are really important when we're assessing our patient as terms of level of the dermatomes for the epidural. As we increase the volume, or we bolus the patient, or the patient gives themselves their bolus, as the volume increases, the level of the anesthetic rises. So your dermatome level, say at the nipple line or the umbilicus, and that's really what we're going to have you guys document as we move into the PCEAs. I can show you the dermatome map here soon in the next couple slides. But a dermatome really is just a mapping of how your brain senses or feels a certain area of your body, and how those two connect and talk to one another. Here is the dermatomes. So like I said, T4 would be really at the nipple line, or T10 would be at the umbilicus. So when you are, and T6 is at the xiphoid. So when you're assessing your patient, you will take a wet alcohol wipe. You'll put it on their shoulder, and it should feel cold. And then you'll start lower, probably at the knee or at the hip, and just work your way up. And when the patient feels that coolness again, that's the level that you're going to be documenting at what level the epidural is at. This is also really important if you get a patient back after a C-section. You know, sometimes if that spinal gets high, they'll feel like they can't breathe. You know, if your patient's saying, hey, I can't breathe, or I have numbness in my hands, really important to do that dermatome test to see if they're complaining of their pinky finger being numb. That's a really quick indication we should be turning off that epidural and calling anesthesia, just so that we can really test to see where that epidural has gotten. Sometimes an epidural can travel. When we're placing it at the low L3, L4, sometimes it can deflect and the catheter can climb up high, so you end up with a thoracic epidural versus a lumbar epidural. Just another picture of dermatomes here. just talking about the early stage of labor, patients really feeling pain about L5, and then late stage, just showing that it's kind of all through the abdomen, and on down to delivery going into the perineum area. So sometimes your epidural can work really, really well in this early stage of labor, and by the time we get to delivery, they're complaining a lot of pressure, a lot of perineum pain, those kinds of things. Sometimes a bolus will help that, and sometimes it just doesn't. A lot of patients can have, if they have scoliosis or different things like that, your epidural may not work as effectively, or may work at some parts of the labor and not at other parts. Again, we'll talk about that stuff a little bit later in the stage too. Possible situations causing inadequate pain relief: morbid obesity and body mass index greater than 30, either very short or very tall individuals, previous spinal surgery and variety of musculoskeletal disorders, and history of a previous placement of epidural catheter, radicular pain during epidural placement, posterior presentation of the fetus, inadequate analgesia from the initial dose, duration of labor more than 6 hours, or technical skills of the provider. We'll start there. Technical skills of the provider. Sometimes if you get a patient who's morbid obese, it's really hard to kind of feel those levels and feel the spine to be able to get your epidural catheter in the correct place. Sometimes all the ligaments and different things are really, really soft, so it's really hard to tell. Say, did I get through that ligament of flavum or not? It's just a guessing game at that point. Short and tall individuals, the shorter people, their I believe that their spinal column is really kind of squished and sometimes really tight, so you're trying to get that epidural catheter through, or the needle at first, and it's just a real struggle to get in between, and sometimes you have to go a little bit higher than your lumbar. You're really not going to get that coverage down below at the end of the labor stage. And then tall individuals need a lot more volume because they have larger area to fill with that local anesthetic, so they may need a higher rate or more higher boluses. Previous spinal surgery, they could have a lot of scarring and different things that are really encasing their nerve roots, which the medication really can't get through to be effective. Same thing with the previous placement epidural catheter. If we cause some scarring or they're at risk for more keloid development than the normal person, they could get some scarring around those areas where the medication really can't get through. Posterior presentation of the fetus, a lot of us have seen this, where just can't cover that area just the way the baby's sitting in there. No matter how many boluses, how many times we change that catheter, really isn't covering when the baby is presenting that way. Inadequate analgesia from the initial dose. Sometimes just need another bolus to kind of get that volume needed for pain relief, or we may just need to replace it. It wasn't placed properly. And then this duration of labor more than 6 hours, your body kind of gets used to the medication and starts going through it like mad, and it's not being effective. I generally see this about, 16 hours later. We're in there bolusing or increasing the rates, and sometimes we just replace the catheter. The catheter's been working the entire time, but just needs to be moved so that different nerve roots are being affected. By troubleshooting unsatisfactory labor, epidural will manipulate the epidural catheter, add more local anesthetic, reposition the patient. This is important. Sometimes you can get a one-sided block, and simply by just turning that patient down on the painful side, it allows that medication to travel and get to the nerve roots that were not getting bathed by the local anesthetic. Sometimes we just have to replace the epidural catheter, like I said, if it's been a long labor. Sometimes, it can pop out of the space just by patients all on fours. It's being moved around, trying to get that baby to come down. We can do a single shot spinal anesthetic where we would do a ITN. I wouldn't normally do this after a epidural has been running, because sometimes you get a large pocket of anesthetic, and if you go through that pocket and you inject into the spinal fluid, you can get a lot more than what you're injecting just by that pocket sitting there. Our hospital really wouldn't do a continuous spinal anesthesia. That's really dangerous. I have done the combined spinal epidural anesthetic, and sometimes if the patient is really uncomfortable, really can't relax, and I'm struggling to get that epidural in, I'll just go ahead and pop in an ITN, help the patient relax, takes away the pain, and then we can get that epidural in. And sometimes all they do need is an ITN. We go ahead and check them, and they're almost complete. We give them a good hour and a half of relief, so that's a good option. Placement of an additional epidural catheter. Again, I don't believe our hospital will go ahead and do this, but other places may add another catheter, or supplementation with intravenous medications. Duramorph is usually one of the ones that we order, but again, I don't think we do that very often. Management, again, of the unsatisfactory epidural. We'll have to look at the type of malfunction, the possible cause of management, insufficient time. Sometimes, depending on what we bolus the epidural with, it just may need a good 20 minutes to half hour. May need some more volume, so you might need to do another bolus. Inadequate percent of local anesthetic. The higher percent of the anesthetic, the more dense of a block you get. So generally, I will use a 3% chloroprocaine. It's fast acting, and it gives a really good block in the beginning. It tells me that my epidural is going to work really well. And I usually top it off with medication, just bolusing it through the pump. It seems to work well. Patient with over expectations. Sometimes I try to tell the patient that every epidural is different. They may have had an epidural that worked out perfectly throughout their whole labor. For whatever reason, this might be very different. And I'll tell them, you know, our goal is to decrease their pain. It may not take their pain away, just make it more manageable. We'll have to allow some more time for it to work, add more volume. We could add opioids, so I could inject some fentanyl into the epidural, or increase that percent of local anesthetic, like I said, using a 2% lidocaine or a 3% chloroprocaine. Satisfactory density of the block, but inadequate segmental levels. So again, it's not high enough, so we may need, again, increase the volume, allow some more time. Somehow we lost volume, check to make sure that catheter is actually connected to the pump. Anatomical factors that we talked about before, previous surgery, scoliosis. Sometimes scoliosis with that twisting and turning of the spine doesn't allow for all the nerve roots to be bathed. Previous injury, so we can redose, give more volume, allow more time, or again, the additional epidural. Previously well-functioning epidural now appears not to be working. So catheter migration, we talked about that, where it could actually migrate up. So if we're having numb hands but our bottom is hurting, that would be an indication that the catheter went north. We'd want to go ahead and turn the epidural off and call anesthesia. So a total spinal, if your patient suddenly feels like everything is really numb, they can't move their legs, they feel short of breath, their blood pressure is dropped, again, that would be an indication that that catheter migrated into the subarachnoid space, would be very dangerous. Go ahead and turn that pump off, call anesthesia. Intervascular, so if that catheter migrated into a vessel, you would see cardiac and neurologic dysfunction. The patient would become confused. You'd see blood pressure dropping. You would see bradycardia. That would be a true emergency. So again, turn the pump off, call anesthesia. In the drawer, you have lipids. You know, I would take a 20 cc syringe and go ahead and give that right to the patient directly, 20 cc's of lipids, and start that infusing. Laterally, a unilateral block, sometimes the catheter is placed too deep, so we go ahead and pull that catheter back, or just simply turning the patient on the painful side. And sometimes the catheter just gets displaced. There's no analgesic effect. Go ahead and check the back of the patient. If you notice a lot of the catheter has been pulled out, go ahead and call us. If it's not working out, we'll have to do something. Labor progression. Sometimes a patient can be just going along just fine, and all of a sudden the body decides, hey, I want to have this baby right now. So it kind of outruns the epidural. And so at that time, call us for a bolus, or hopefully we'll have this PCEAs running and the patient can go ahead and bolus themselves. Dysfunctional labor, patient's just not making progress. The baby's in there kind of cockeyed, those kinds of things could cause the epidural not to work so well. Patient's perception change. Sometimes they're just done, and they will say, I'm in severe pain, I'm uncomfortable, this little spot right here hurts. They just want this baby out. Again, just knowing your patient and just really trying to decide, is this true? You know, is this epidural really working and the patient's just emotionally done? Look at the catheter. We can redose, add more volume, add opioids, increase the percent of local anesthetic, or we may have to replace that epidural. Sacral sparring. Sometimes epidurals are placed typically at L3, 4, L4, 5. That first stage of labor is visceral. It's carried by the T10L1 nerve roots. They innervate the uterus, the cervix, and the upper portion of the vagina. Second stage of labor is somatic and carried by S2, S4 nerve roots innervating the perineum. Second stage of labor is more painful. These nerve roots are further down from the tip of the epidural catheter, larger in diameter and surrounded by thicker dura, which makes it more difficult for local anesthetic to penetrate. So that makes sense. Sometimes I'll get a call that the patient is now really uncomfortable and, again, their labor has picked up in intensity and they're just having more pain. So sometimes just bolusing that patient will take care of that pain. Just we'll be able to give a larger volume that will hopefully sink down to that S2, S4 area in order to give them some relief. Epidural infusions tend to transfer upward more readily than downward. And sometimes just bolusing them and having them sit up so that that medication will sink rather than going up. Patients with chronic back pain, they have increased epidural failure. Patients with unilateral or sciatica, the affected nerve roots become blocked 10 to 70 minutes later than nerves from the contralateral side. The local anesthetics have a difficult time diffusing in an injured site. So again, that scarring makes it really challenging for the medication to penetrate and do its job. So just time or more volume may help these patients. And patients with scoliosis, difficult placement. With their scoliosis, they not only have the spine that's turning, but it's also twisting. So to try to get something that you would think should be straight on, you actually have to turn your needle at a diagonal to try to access their spine. Not fun at all. Unpredictable local anesthetic spread and diffusion. Here we're going to talk about anticoagulants. So any patient that's on any type of anticoagulant, antiplatelet, or fibrolytic or thrombofibrolytic drugs, just let us know. Sometimes when we're looking at EPIC, all the information's not in there all the time. And if you know your patients on these types of things, let us know, because we really have to be careful not to be placing epidurals on patients who are on anticoagulants. I just want to make sure that we're checking the PTTs and INRs. So just really let us know so we can make a good plan for these patients so we don't end up with this spinal hematoma. Standard heparin, sub-Q heparin use is not contraindicated in patients with epidurals or spinals. Risk of bleeding can be reduced by giving sub-Q heparin at least 1 hour after the spinal or epidural and removing the catheter 1 hour before sub-Q heparin is given, or 2 to 4 hours after the last dose. So, if your patient's on heparin, just really remember to take a peek at this module or protocol to make sure that you're pulling the catheter at the correct time. Low molecular weight heparin places the patient at increased risk of spinal hematoma. In extreme cases, which epidural or spinal is required to follow these recommendations, single dose spinal 10 to 12 hours after the last dose, and removing that catheter prior to starting the low molecular weight heparin 10 to 12 hours after the last dose. Again, just go back to your resources to make sure a little light bulb comes in your head when you see these types of patients that, hey, I really should go look back and see when we should be doing certain things. Onset and duration action of commonly used opioids and epidurals. This is really, really important. An opioid's ability to dissolve in the fat, lipid solubility, influences its onset and duration of action. Drugs that are highly lipid soluble, fentanyl, meperidine, have a fast onset of action and a short duration. Highly lipid soluble drugs have a short mechanism of action due to rapid vascular absorption and slow restoral diffusion in the CSF. Elimination occurs at the arachnoid granulations. So fentanyl and meperidine have that fast onset of action and a short duration. These are safer medications to be using versus your water soluble. We'll get to those. So your hydrophilic drugs, water soluble, are your morphines and your hydromorphones. These medications are the ones that we are adding to our ITNs when our patients are having C-sections. They do not penetrate the membranes as easy as lipophilic drugs, and diffusion is slow. Onset is slower and mechanism of action is longer. Greater dermatomal spread than the lipophilic drugs, providing analgesia in larger areas. So that makes them really, really beneficial for C-sections. This is just a chart that shows you morphine lipid solubility versus hydromorphone, and then the onset durations and the durations. So you can go ahead and look at those. This is where it becomes important to kind of understand how these drugs are working. Respiratory depression. In the hydrophilic opioids and morphines and hydromorphones, they cause respiratory depression at 2 very distinct times. Early respiratory depression happens soon after administration, But the big one is that delayed onset respiratory depression. That can occur up to 24 hours after administration. So we really have to be monitoring these patients' respiratory status. They should have a SAT monitor on it for the first 24 hours after that ITN is placed. This is another reason why we have that 12-hour window. After placing an ITN, you'll see those 12-hour post-op ITN orders, and we get phone calls, hey, can we give oral meds and those kinds of things. And we just want that communication with us so that this patient isn't getting IV medications on top of oral medications and creating this respiratory distress 24 hours later. Again, side effects of the epidural opioid analgesia, the respiratory depression, lipophilic opioids, the fentanyl and meperidine, they have delayed onset respiratory depression, is less likely to occur. These medications are less likely to spread respirally. Early onset respiratory depression, possibly due to easy penetration and uptake. So fentanyl is the drug that's in our epidural, so a lot less risk for this respiratory depression, but it can happen. The patient is at great risk for respiratory depression and death if IV, IM, or PO opioids are given with an infusing epidural. Again, with your patient having that fentanyl being infused through the epidural, it's really important to be mindful of not giving any other opioids during that time. Side effects of epidural opioids and analgesia, nausea and vomiting. After talking with the group, they're not seeing this very much. Vomiting, just being in the transitional phase of delivery, that can happen. I think we have just a lower dose of fentanyl in the epidural, so you're not really seeing too much of that. Due to the restoral spread of the opioid in the CSF and the chemoreceptor trigger zone in the brainstem is what's causing that nausea and vomiting. 17% of patients will experience nausea and vomiting can be well controlled with antiemetics, and usually we're using Zofran. Pruritus or itching is a common side effect of epidural opioids that is not clearly understood. Patients usually complain of itching of the face and chest with no apparent rash noted. It is hypothesized that the itching is due to alterations in the spinal and trigeminal nerve processing. The modulation of nociceptive input is interpreted at a higher level as an itch. An option for treatment of this pruritus is Nubain, which is a mixed opioid agonist-antagonist. Nubain antagonizes the mu-opioid kappa receptors, which produces analgesia. So after giving Nubain, your patient will get more relaxed and a little bit more sleepy, but it will take away that itching. Local anesthetics. Local anesthetics block nerve conduction, results in the inability to modulate pain while motor function remains intact, providing what's called differential block. An increased volume and higher percent of local anesthetics into the epidural space will produce a motor block. So if your patient is complaining of a lot of pain, a lot of us will bolus that patient with either 2% lidocaine or 3% chloroprocaine. You may notice after that your patient's not able to move their legs as well as they once were. Chloroprocaine will wear off within about 2 hours, and the lidocaine 3 to 4 hours. Ropivacaine is commonly used in epidural infusions. It's quick onset with long duration of action. It provides the best sensory block with minimal motor block. So you will see us using ropivacaine in our epidural infusions. It's a great little cocktail there. Adverse effects of local anesthetics. Systemic local anesthetic toxicity. This is what we talk about when we inject a large volume of local anesthetic directly into the bloodstream. Very, very scary situation. It's high blood concentrations of local anesthetics. Blood concentration is affected by the dose of the drug, the site of injection, speed of injection, and inadvertent injection directly into the blood vessel. So when we are doing our test dose, it has epinephrine in it, and so you'll hear most of us say, hey, is that pulse ox on? Because we want to hear if the pulse increases with that epinephrine. And we're testing for just this to make sure we're not in a blood vessel, that when we were threading that catheter, we didn't accidentally access the blood vessel, get close to a blood vessel, any uptake into the bloodstream, because that would be very dangerous. The systemic side effects, we'll talk about the central nervous system, lightheadedness, dizziness, metallic taste, ringing in the ears. Those would be early stages of local anesthetic toxicity. Might progress into excitatory phase, which would be shivering, muscle twitching, tremors, generalized convulsions, CNS depression resulting in respiratory arrest. If you feel like your patient is getting lightheaded and dizzy, and you know the blood pressure isn't low, which you could be giving ephedrine for, really have this in the back of your mind that it could be a real central nervous system problem, and just watch for shivering, tremors, those kinds of things. Turn that pump off, and again, those lipids are in the second or third drawer in the epidural cart. Go ahead and draw 20 cc's, inject that into the IV as somebody else is getting the infusion started. Adverse effects of local anesthetic, systemic side effects, cardiovascular. You see hypotension, myocardial depression, cardiac arrest, and death. Again, really hard to tell. Hypotension, that's pretty common with epidurals, but just being really mindful and on your game about assessing your patient and watching for the other signs. You're going to provide ACLS, administer medications, IV fluids as ordered, notify MD and anesthesia, administer O2, initiate CPR if needed, monitor maternal and fetal status, and prepare for possibility of lipid rescue. Here we're going to talk about assisting with the positioning of the patient for the epidural placement. Usually we'd like the patient sitting on the edge of the bed, pretty high up in the bed, because there is that lumbar support in those beds that really create a non-level area to work. You want both knees against the back of the bed, sitting position with the back flex. So as we're working with this patient and we're looking at their back, we're not always in tune to their shoulders, and sometimes it's common for them to start drifting to one side or the other, which makes it really difficult for us to place an epidural. Also, they tend to start stiffening up because they're tense and they're concerned about us working back there. So really just helping them relax their shoulders and pushing their belly button to the back, that really arched rainbow, as Galen would say, would work well for us. Once the patient's in proper position, we'll prep and drape the patient's back. The nurse will assist the patient with relaxation and remaining still in the proper position. Local anesthetic is placed on the skin. This will most likely cause some burning sensation. From there, the patient normally will just feel pressure. The anesthesia provider will then begin placing the epidural. The patient will feel a lot of pressure on the back at this time. Once the provider feels as if he or she has entered the epidural space, the provider will give a test dose of local anesthetic. Once confirmed, the catheter will be secured with an occlusive dressing. And then we go ahead and tape that down really well so the patient doesn't inadvertently pull that out. Some common medications that we'll be using with the PCA parameters. So the fentanyl with the 2 mics per mil and the ropivacaine, which is 0.2%. The minimum continuous dose will be 8 mils with a max of 14 mils per hour. The patient will be able to bolus themselves with 4 mils with a maximum of 3 boluses per hour. And then max hour limit will be 26 mils. Medications that you'll have would be ephedrine, 10 milligrams IV, Q2 minutes for blood pressure. Usually we say less than 100, but if the patient is preeclamptic and they're used to having a blood pressure in the 180s, 190s, we'll probably bump that up to 120, 130s. It'll be per the provider, and they'll write those orders. We'll give some Zofran for nausea, some Benadryl, some Nubain for itching, and then the Naloxone, if your patient becomes obtunded, will reverse the narcotic effects of that. Your role for monitoring the patient is assess the laboring woman's level of pain, discomfort, and desire for non-pharmacologic and pharmacologic approaches to pain relief, provide education about her options, assess maternal baseline blood pressure, pulse, respiratory rate, and temperature. If patient desires an epidural, analgesia, oral intake must be limited to clear liquids only. Notify the provider and obtain an order for epidural, analgesia. Obtain fetal heart rate tracing prior to epidural placement and continue assessment during catheter placement if possible. So again, going back to just letting us know if the baby hasn't been doing very well, we may decide to hold off with that epidural catheter. Insert an 18 gauge peripheral IV. Infuse 1,000 mL of LR over 20-30 minutes prior to epidural placement. Ensure the emergency equipment and drugs are readily available. Anesthesia provider will conduct a pre-procedure verification process and pre-anesthesia assessment. It is the responsibility of the anesthesia provider to explain the procedure, risks, and benefits and obtain informed consent. It is the responsibility of the anesthesia provider to provide the patient with initial education on the use of the PCEA system. Conduct a timeout before the procedure. The anesthesia provider will prepare the infusion and the pump. The OB nurse is responsible for double checking the dosage. All epidural infusions containing narcotic will be administered via locked epidural pump secured to an IV pole. The anesthesia provider will order the medication infusion parameters, and the OB nurse will assist the anesthesia provider in positioning the patient for the procedure. Encourage and assist the patient with breathing and relaxation techniques during the procedure. Sometimes the husband or the partner would like to help the patient relax and hold their shoulders and those kinds of things during the procedure. But it would be really helpful if the RN could sit by and just make sure that they're doing a good job with that role. You know, to provide one-to-one nursing care during the epidural placement and for at least the first 30 minutes thereafter. Really important to stay with the patient during that time. Their blood pressure could be holding steady just fine, and all of a sudden they'll go from 120s to 80, and the patient's not feeling very well, and if nobody's in the room with them, the patient could keep going down with the blood pressure, then turn into the baby not doing so well. Pulse oximetry should be used continuously during the test dose and initial bolus period. Monitor and record SATs a minimum of Q1 hour if the patient is stable. Record blood pressure every 5 minutes times 4, every 15 minutes times 2, then every 30 minutes provided the patient is stable while the epidural is infusing. And again, if we need to take blood pressures more often because their blood pressures are kind of drifting, that is just an assessment skill that needs to take place there. Blood pressure should be recorded every 5 minutes times 4 following a clinician-delivered bolus. So if we were to come in and bolus the patient, we need to have those blood pressures every 5 minutes again, times 4. Record dermatome level, respiratory rate, pain score, and station score minimum once per hour. Continuous fetal monitoring is required while the epidural is infusing. I know some of our patients don't want any monitoring, but it is really important while these epidurals are infusing that we hold to our protocol. The total volume of epidural medication delivered should be recorded every 4 hours. If the patient has inadequate analgesia, consider the following interventions. Check the epidural insertion site and catheter connection sites. Confirm that the epidural infusion pump is working. Consider evaluating the progression of labor. Confirm the patient is utilizing the bolus feature appropriately. Record the number of bolus attempts, bolus deliveries, and total volume infused over the last 4 hours. Reposition the patient and activate the bolus feature. Reevaluate the pain score in 15 minutes. If all else fails, give us a call. Post-procedure ongoing maternal fetal assessment. Patient should be continuously attended for the duration of the regional analgesia anesthesia. This may include a support person, but the nurse must be readily available. In collaboration with anesthesia, the nurse will assess the effectiveness of the analgesia, the presence of the adverse effects, and the woman's ability to cope with labor. Monitor for intravascular injection of local anesthetic. If this occurs, call for help. Notify OB and anesthesia providers. Protect airway. Initiate resuscitation protocol. Evaluate and document maternal pain levels a minimum of every 1 hour. Ensure the patient has an understanding of how to use the patient-controlled epidural system. Maintain maternal blood pressure and minimize hypotension. Facilitate lateral or upright position with uterine displacement. A hip wedge, lateral positioning, or semi-followers may also be used to maintain uterine displacement. If the patient becomes hypotensive, attempt the following. Give ephedrine as ordered and consult anesthesia, and reposition the patient. If indeterminate or abnormal fetal heart rate patterns are identified, initiate intrauterine resuscitative measures, maternal position change, IV fluid, oxygen, and notify OB and anesthesia. If excessive uterine activity occurs, initiate maternal repositioning IV fluid bolus. If these measures are ineffective, consider decreasing or discontinuing the oxytocin if infusing. The OB/RN may pause the epidural infusion pump to replace an empty bottle with a pre-prepared solution containing the same medication and concentration that was infusing. The RN may restart the infusion. Remove the epidural catheter when analgesia is no longer desired. Document the removal of the catheter and the integrity of the tip. Evaluate the postpartum woman's readiness to ambulate and potential fall risk. And all ambulations should be assisted and observed for 4 hours after the infusion is stopped. Assessment and management of potential complications. Headache. The signs and symptoms of a post-dural puncture headache include increased pain in the upright position that is relieved in the supine position, neck pain or stiffness, nausea or vomiting, photophobia, diplopia, hearing loss, and tinnitus. Intervention. Provide psychological support, increase oral fluid intake, encourage caffeinated beverages, and consult anesthesia. Urinary retention. Assess for bladder distension by observation and palpitation. Assist woman to void, bladder scan if unable to void, and straight cath if needed. For itching, assess for the presence and severity of itching. Follow the PRN medication orders for itching. If itching is not resolved in 1 hour, contact anesthesia. Nausea and emesis. Monitor for nausea and vomiting. Assess for maternal hypotension. Administer PRN meds as ordered for nausea and vomiting. Use aspiration precautions in the event of emesis and notify provider if emesis is excessive. In the event of an intravascular injection following administration of regional anesthesia, assess for signs of intravascular injection, including ringing in the ears, metallic taste in the mouth, perioral anesthesia, so like numbness around their mouth, restlessness, dizziness, loss of consciousness, seizure, elevated blood pressure, tachycardia, bradycardia, VFib, and cardiac arrest. Stop the infusion and call for help and initiate the emergency protocol, including lipids. Routine assessment of the newborn, including temperature, heart rate, respiratory rate, skin color, muscle tone, activity should be documented every 30 minutes until the newborn's condition has remained stable for 2 hours. You all know this. It's part of your protocol, not mine. Initiate neonatal resuscitation if necessary according to NRP guidelines, and administer a narcotic antagonist as ordered for respiratory depression. It is important to do a respiratory rate sedation scale. 0 is the patient's alert. 1 is occasionally drowsy, easily aroused. 2 is moderate, frequently drowsy, easily aroused. 3 is severe, somnolent, difficult to arouse. And S is asleep, normal sleep, easily aroused. You can check that every 30 minutes for the first hour, then hourly. Repeat sequence after each change in dose. Level of epidural sensory changes. Use dermatome scale to describe level. Assess by checking patient's perception of cold. We talked about this earlier in the slides, just touching the patient's skin at the shoulder with alcohol wipe along mid-clavicle line. Ask if it feels cold. Move downward, testing every 1 to 2 inches until patient perceives wipe as warm. Level should be between T8 and T10, so between the umbilicus and the lower part of the xiphoid. Also assess the patient's ability to lift legs every 1 to 2 hours. Pain relief using that 0 to 10 pain scale. This is kind of important. I know it seems kind of silly, but it really will gauge, is this epidural changing? Has it been the same? Have they been remaining in their pain 5 all day long, but they've been sleeping? It really does give us a really good indication on when things have changed. When did they go from a 2 to a 10? What were the precipitating factors? According to the NC Nurse Practice Act, RNs are not to dose epidurals or adjust epidural infusion pumps. Notify anesthesia provider if epidural is not providing pain relief. So you're going to look at the respiratory rate. If it's less than 8 per minute or a score of less than 3 or less on that awake sedation scale, you're going to turn off the epidural infusion, initiate Narcan protocol, and notify anesthesia stat. Change in sensory or motor sensation. If the patient's unable to feel cold at the level of the xiphoid and above desired level, you're going to turn off that epidural and notify us right away. So if that started moving up, they started getting numb hands, numb face, those kinds of things, that's something to go ahead and turn that pump off and give us a call. Epidural abscess. This is really, really uncommon, but it could happen. So assess the catheter insertion site every 8 hours for signs of infection, tenderness, swelling, drainage. Assess for changes in sensory motor function every 4 hours. If suddenly their legs became more numb than they had been, unable to have a bowel movement or bladder dysfunction, fever or neck stiffness, all reasons to be calling us for that. Checking for a hematoma. We're going to be assessing catheter insertion site every 8 hours for pain and or swelling at the site. Assess for change in sensory and motor function every 4 hours, including progressive numbness, weakness, or bowel and bladder dysfunction. Warning, do not administer low molecular weight heparin without first advising anesthesia department. So again, any heparins, anything like that, let us know first. And if you feel like doing these pre and post tests, have at it, but otherwise good luck to you, and if you ever have any questions, feel free to give us a call.